May I introduce the guest speaker today, who is Dr. Abdurrahman. He's a postgraduate resident, year 3, and registrar at the Department of Psychiatry and Behavioral Sciences at Services Hospital and Services Institute of Medical Sciences, Lahore, Punjab, Pakistan. And I've worked in the same department for almost a year, and this is one of the best training departments in the whole Pakistan, not only in Punjab but in whole Pakistan. This is one of the best.
So the topic of my presentation today is psychosis, schizophrenia, and antipsychotics. We will be talking about the neurotransmitters, receptors, and brain circuits that are involved. The learning objectives are, first of all, we'll have a brief introduction on psychosis and schizophrenia. Then we'll see why should we even bother about pathophysiology of different psychiatric illnesses. And then we'll talk about neurotransmitter and pathways implicated and hypothesized to be involved in schizophrenia. And then we'll look at antipsychotic pathways that are responsible for their therapeutic actions, and then the brain pathways which are responsible for the side effects of antipsychotics. And finally, we'll just see a few newer novel antipsychotics that are in development or have recently been approved. We'll see how they work and how they exert their antipsychotic actions. So first of all, a brief look at psychosis and schizophrenia. I'm sure you are all familiar with this. So psychosis is an old term, and in the old times, it was used to differentiate psychotic illnesses from neurotic illnesses. In the psychotic illnesses, insight was impaired. Patient had lost his contact with reality, while in neurotic illnesses, insight was not impaired. So this is an old classification. The generally, when we say psychotic symptoms, we mean the following symptoms: hallucinations, delusions, disorganized behavior, disorganized speech, and negative symptoms. Now, all these symptoms are psychotic symptoms and a part of psychosis. However, what I want to emphasize here is that every psychosis isn't schizophrenia. Sure, schizophrenia is a leading cause for psychosis, but there are certain criteria without which we cannot diagnose schizophrenia. Now, when we think of schizophrenia, when we imagine a schizophrenic patient, we only imagine and focus more on these positive symptoms. But for the patient, maybe these negative symptoms also hold a lot of importance, and especially with regard to their functionality, these are really important. So moving on, why should we even bother about pathophysiology? We can just treat our patients with antipsychotics. Why do we even need to know why schizophrenia happens? So in order to answer that, let's look at the evolution of medical science. In the early part of the previous century, medicine was syndromal, a cluster of symptoms used to define an illness, and that was used to diagnose the illness as well. However, these days we know the pathophysiology of many medical illnesses down to the molecular levels. And now the advantage is that we have a lot of sophisticated laboratory investigations, and we have very targeted therapies with fewer side effects. In this sense, psychiatry is a bit primitive. Still, we are syndromal in our classification and diagnosis. So for instance, if a patient has a cluster of symptoms, let's say hallucinations and delusions, we would say that the person has schizophrenia. If the person has depressed mood and anhedonia, along with a variety of symptoms, that person would have major depressive disorder, but we don't really know the exact causes. There has been a lot of research, and unfortunately, no single cause has been identified for any of the psychiatric illnesses. In fact, like diabetes and hypertension, most of the psychiatric illnesses are also multifactorial. They have multiple etiologies. So, speaking about schizophrenia, let's see what are the current thinking about how schizophrenia happens, about the pathophysiology of the illness. So first of all, genetics have been implicated, although we haven't been able to find single genes for schizophrenia. However, several genes have been implicated, each with a minor effect for increasing the risk of having schizophrenia. Several genes include DISC1, neurogulian 1, and several others. Then there is the neurodevelopmental hypothesis for schizophrenia, that there is some insult during the neurodevelopmental period, and that is why patients have schizophrenia. Furthermore, many environmental and psychosocial factors like childhood abuse, marijuana smoking, cannabis abuse, viruses and toxins, and traumatic experiences, all of these predispose to causing schizophrenia. Now, all these three factors, these are predisposing factors, they converge on a single mechanism. They cause the abnormality of specific neurotransmitters or receptors. Then, abnormalities in these neurotransmitters lead to malfunction of specific brain circuits, and this malfunction is responsible for several symptoms of schizophrenia that are manifested. So now, in the rest of the presentation, we'll be concerned about this lower part of the slide. We will be interested in finding out the abnormalities of neurotransmitters and circuits, and how antipsychotics may improve these abnormalities and bring the patient back to normality in terms of mental health. So this is diagrammatic illustration. The top part shows a normal person, and this shows normal levels of dopamine, serotonin, and norepinephrine and glutamate. There is no psychopathology here. So in case of schizophrenia, the three monoamines, dopamine, serotonin, and norepinephrine, are hypothesized to be increased, while glutamate function is hypothesized to be reduced. In depression, all the three monoamines are decreased or their function is decreased. In bipolar affective disorder, especially in mania, where there is hyperactivity of the entire nervous system, there is increased level of serotonin, norepinephrine, and glutamate, and most of the mood stabilizers act on this glutamate pathway and reduce the glutamate hyperactivity in bipolar affective disorder. In anxiety disorder, among other neurotransmitters, serotonin has a prominent role. This is an actual photograph of a human brain taken from a cadaver. And this is a sagittal section, and it shows numerous structures. This anteriorly is the frontal lobe, then this one in the middle is the parietal lobe, and behind the calcarine sulcus is the occipital lobe. This is the corpus callosum. This egg-shaped structure is the thalamus, and then here we have the brainstem. Brainstem is divided further into midbrain, this upper part, this swollen part is the pons, and finally this stem-like structure is the medulla. So let's try to visualize the several pathways involved in the pathophysiology of schizophrenia and mechanism of action of antipsychotics. So let's look at the various dopaminergic pathways that are present in the brain, and as we'll see later, these have a central role in the pathophysiology of schizophrenia. So one pathway is going from the midbrain to the nucleus accumbens, which is a part of the limbic system. Nucleus accumbens is the reward center of the brain. Whenever we have any pleasurable activity, dopamine increases here. And several drugs of abuse, they cause massive release of dopamine in this structure, and that is why they are associated with a feeling of euphoria, or as it is commonly called, a high associated with the drugs. So this is also implicated in schizophrenia, and we'll see later how. All right, then we have a pathway going from the midbrain to the prefrontal cortex. This is called the mesocortical pathway. So meso is from mesencephalon, which is the midbrain. It is another name for the midbrain. And prefrontal cortex, so it is mesocortical. And by the way, the previous pathway was from mesencephalon to nucleus accumbens, which is a part of limbic system. So this pathway was the mesolimbic pathway. Then there are other dopamine neurons in the midbrain as well, and these give rise to another pathway to the basal ganglia, which is also called striatum. There is a substantia nigra structure in the midbrain, and this pathway runs from substantia nigra to the striatum. This is the nigrostriatal pathway. Finally, from the hypothalamus, another dopaminergic pathway is going to the pituitary gland, and this is called tuberoinfundibular pathway. So that was just a summary of the pathways. We'll look at them in more detail later. So as you might have surmised by now that the source of all dopamine, at least most of the dopamine in the cerebral cortex, is the midbrain. So let's have a look at the midbrain under a microscope to find out exactly what sort of dopamine neurons are present there. So we are looking at a cross section of the midbrain at the level of superior colliculus. Two major population of dopaminergic neurons. All these red neurons, these are the dopaminergic neurons. One population is in the center. This is known as neurons of the ventral tegmental area. Now, these give rise to the mesocortical and mesolimbic pathway that we already discussed. And these are the source of those circuits that are central to the pathophysiology of schizophrenia. And then on the sides of these ventral tegmental area neurons, there are other dopaminergic neurons that are collectively known as substantia nigra. And they are particularly implicated in movement disorders like Parkinson's disease, where they get degenerated. The mesolimbic pathway was going from the midbrain to the nucleus accumbens. And when this pathway gets hyperactivated, then we have the positive symptoms of psychosis. So this hypothesis states that hyperactivity of dopamine in this pathway causes positive symptoms of psychosis. Now, whatever the cause of psychosis, whether it is a part of dementia, whether it occurs due to substance abuse, or whether it occurs as a part of affective disorder, the final pathway for positive psychotic symptoms is increased dopamine in the mesolimbic pathway. Now, as I already said, nucleus accumbens is our reward center, and many drugs of abuse increase dopamine in this reward center. And therefore, it is no surprise that many of the same drugs of abuse induce positive symptoms as well, because they will increase dopamine in the mesolimbic pathway. And this has been associated with positive symptoms such as hallucinations and delusions. So these two neurons, these show the ventral tegmental area, the one at the center. This green structure is the nucleus accumbens. Mesolimbic pathway, as already discussed, was going from ventral tegmental area in the midbrain to the nucleus accumbens of the limbic system. Now, this is the mesolimbic pathway, and these lightnings, they show that there is hyperactivation of this pathway, and this leads to positive psychotic symptoms. Now, this is from Stahl's Psychopharmacology, 4th edition, one of my favorite books as far as pathophysiology is concerned. So they are showing much of the same thing. This is showing the mesolimbic pathway, and it is colored in red, which is showing that it is hyperactivated. There is a lot of dopamine in the synapse, and because of this, this person is having auditory hallucinations, and delusions of reference that people are actually talking about him. So that was it for these positive psychotic symptoms, but equally important are the negative psychotic symptoms, negative symptoms of schizophrenia, and there is a completely different pathway for those symptoms. This pathway is the mesocortical pathway. There are two main branches of this pathway. One goes to the dorsolateral prefrontal cortex, and it is responsible for cognitive and negative symptoms of schizophrenia. And then there is another one that goes to ventromedial prefrontal cortex, and this mediates affective and negative symptoms. Okay, so now we visualize the mesocortical pathway. That was the mesolimbic pathway. So prefrontal cortex has been divided into two parts. One is the ventromedial prefrontal cortex associated with emotions, and the other is dorsolateral prefrontal cortex associated with our cognitive functioning. So this pathway has two branches. One goes to the dorsolateral prefrontal cortex, and the other goes to the ventromedial prefrontal cortex. When dopamine is reduced in this pathway to the dorsolateral prefrontal cortex, this would cause cognitive dysfunction in schizophrenia. And when this other pathway is disturbed, this will cause affective and negative symptoms of schizophrenia. So this is from Strauss again, and it is showing the same thing. When the pathway to the dorsolateral prefrontal cortex has low dopamine, this causes negative symptoms. This person is having anhedonia, and this also causes cognitive symptoms, as I already mentioned. When the same pathway has reduced dopamine in the ventromedial prefrontal cortex, then there can be affective symptoms and negative symptoms. So these two pathways, the mesocortical and mesolimbic pathways, are the main targets for our antipsychotics. And as we will see later, antipsychotics are very good at acting on the mesolimbic pathway. However, they do little to nothing on the mesocortical pathway. So let's move on from schizophrenia to antipsychotics. So antipsychotics are substances that have dopamine 2 antagonism. So dopamine 2 is a receptor involved in the action of dopamine. And as we already saw, dopamine was hyperactive in the mesolimbic pathway. Those disturbing symptoms, those disruptive symptoms of hallucinations and delusions, they were determined by hyperdopaminergia, hyperdopaminergic state in the mesolimbic pathway. So these are dopamine receptor antagonists, and they act on the mesolimbic pathway, reduce the overactivation, and hence reduce the positive symptoms of schizophrenia. However, they are indiscriminate. They don't just target the mesolimbic pathway. When they reduce dopamine elsewhere in the brain, they will cause side effects. And one of the major side effects that is especially prominent with the first generation, we'll talk about the generation later. One of the major side effects is that they worsen instead of improving the negative symptoms. So they are dopamine antagonists, and we are already having reduced dopamine in the mesocortical pathways that is causing the negative symptoms. So antipsychotics would decrease already decreased dopamine in these pathways and would worsen instead of improving the negative symptoms. Antipsychotic that would be perfect would only target the mesolimbic pathway. It would decrease dopamine in the mesolimbic pathway, while at the same time it would increase dopamine in the mesocortical pathway. So that is the need for a perfect antipsychotic. We need an antipsychotic that has opposite actions on both of these pathways. And we don't want dopamine affecting, we don't want antipsychotics affecting dopamine in other pathways of the brain, and that would minimize the side effects. However, an ideal antipsychotic is still not present. Several antipsychotics are in research, but we have been unable to find such an ideal antipsychotic that has such specific actions in the brain pathways. For almost all the antipsychotics, they reduce positive symptoms by causing antagonism in the D2 receptor. Now, there are three antipsychotics that are partial agonists, and we'll do the details of a partial agonist later. These are aripiprazole, brexpiprazole, and cariprazine. Theoretically, they reduce positive symptoms on the one hand, while improving negative symptoms and cognitive symptoms on the other hand. However, this has still not been clinically proven. Okay, serotonin receptors are also acted upon by antipsychotics, especially the second generation antipsychotics. So serotonin 2A receptor may have an antipsychotic effect, and it also indirectly increases dopamine in the nigrostriatal and tuberoinfundibular pathway. So second generation antipsychotics, through their antagonism of serotonin 2A receptor, they compensate for D2 antagonism. So they reduce the side effects that are present because of D2 antagonism. In particular, they have reduced movement and hyperprolactinemia side effects. Then serotonin 2C receptor antagonism, many antipsychotics cause this, including olanzapine and clozapine and quetiapine. And this has an antidepressant effect. And this receptor is theorized to underlie the strong antidepressant effect of fluoxetine-olanzapine combination that is often employed in bipolar depression and resistant depression. Then serotonin 7 receptor, lurasidone acts on it, and several other antipsychotics, and this is also thought to have antidepressant action. Accordingly, lurasidone has antidepressant action in bipolar depression and has been approved for this indication. Histamine receptor, almost all antipsychotics cause sedation by acting on histamine 1 receptor. Side effect of this is that it increases appetite as well, and so weight is also increased. So we talked a bit about first generation and second generation. Basically, this is an older terminology. Those that were discovered first, they were known as the first generation, and those that were discovered later were known as second generation. There is also mechanistic differences. First generation antipsychotics like haloperidol have large therapeutic action only because of their D2 blockade, while the second generation antipsychotics like olanzapine, like clozapine, they also act on other receptors as well, such as serotonin 2A receptors and several other serotonin receptors, and have because of that they have other properties in addition to antipsychotic properties like antidepressant actions, anti-obsessive actions, and anti-manic actions. And now this is one of the most complex receptor profile for any medicine known to psychiatry and maybe known to medicine. This is clozapine, and it acts on more than 50 receptors. Let's see which receptors are responsible for which of its effects. The antipsychotic action is because of D2 receptor antagonism and serotonin 2A antagonism. Antidepressant actions are because of serotonin 2C antagonism, serotonin 3 and serotonin 7 antagonism. Now, clozapine has a proven role as an anti-suicidal agent in psychosis. So that could be because of these antidepressant actions. it also causes sedation, which can be a side effect or can be a therapeutic effect in many patients with schizophrenia, where we are looking to sedate the patient in order to prevent harm to self and others. This is because of H1 antagonism and M1 antagonism. So weight gain is because of the combination of serotonin 2C and histamine 1 receptor antagonism, and orthostatic hypotension. Another side effect is because of alpha 1